തുടങ്ങിക്കോട്ടെ സാറേ, തുടങ്ങിക്കോട്ടെ.
Sure, yes, ma'am.
So good morning all of you. I'm Dr. Dahlia. In spite of the ongoing advancements which are happening in ophthalmology in day-to-day practice, there'll definitely be a group of people who require spectacles, and a proper assessment and prescription is absolutely necessary to satisfy these patients. So let us see the steps to reach an endpoint to give a proper prescription to these patients. So our first speaker will be Dr. Sudha from Kasturba Medical College, Manipal, who will speak on objective refraction. Over to you, Dr. Sudha.
Shall I start with big thanks to Dahlia and the KSOS for inviting me here. I get to see all my friends again. So why is objective refraction important? It's because if you do subjective refraction without some mode of objective refraction, it's like looking for a needle in the haystack. It's like a blind procedure. So the techniques available are either retinoscopy or autorefractometry. With the increasing use of autorefractometer, is retinoscopy becoming a dying art? I think so. So why should you know retinoscopy? Because it is important when subjective refraction is not possible. In infants and children and uncooperative adults. Also in the OT, you have a child under anesthesia, you have to know retinoscopy. Of course, Quitella, okay, sorry. And if you have handheld autorefractometers, good. Otherwise, you have to know retinoscopy. It's also a screening tool for keratoconus and other media opacities. But the most important thing is that you need to know retinoscopy the day the AR machine conks off and your optometrist also skips work. Cycloplegic retinoscopy, what are the indications for infants and children? Because they have a maximal accommodation. The amplitude of accommodation. Children with ESO deviations, you have to bring out the total hypermetropia. In young adults with significant asthenopia, when your subjective and objective refraction do not tally. Also, when you're doing dry retinoscopy, you see there is fluctuating accommodation. That is, initially you see that it's a with movement, and then you see there's an against movement. You know the patient is accommodating. Then you need to do a cycloplegic retinoscopy. In all other instances, you have to do a dry retinoscopy. So I'm not going into the theory part. Basically, it is based on Foucault's principle, that is, you're trying to find out the far point of the eye. So if the patient is emmetropic, the emerging rays, so you're basically illuminating the eye, the subject's eye, and you have rays emanating from the eye. And if the eye is emmetropic, the emerging rays are parallel. If myopic, the rays will converge, and if hypermetropic, the rays are divergent. So you're trying to sit at the patient's far point. So if the examiner is at the patient's far point, all light leaving the eye will enter the peephole of your retinoscope, and illumination is uniform. So basically, neutralization is bringing the far point at the peephole of your retinoscope. So what are the advantages of the streak retinoscope? That is what we all use now. It is self-illuminated, it's easily manipulated. You can control the intensity and the type of the beam. You can, the axis of the cylinder, you can easily estimate because you can tilt the retinoscope. High refractive errors, we have a concave mirror effect. I'll speak to you about it. So basically you have two settings. You have a plane mirror setting and a concave mirror setting. So with the Welschalin model, when you pull the sleeve down, you have the plane mirror setting. So that is commonly used. Very rarely you need to use the concave mirror settings. That is when the sleeve is up. So it's usually used only if you want to, sharpen, you want to find the axis of the cylinder and you want to sharpen the reflex. So with a plane mirror, you get a broader reflex. With a concave mirror, you get like a thin streak. So it helps to find the axis of the cylinder. In high refractive errors, there's a thing that's called pseudo-neutralization. I'll explain that later. So a few tips for the procedure of retinoscopy. Do not sit directly in front of the patient, because then the patient is going to look at you and accommodate. So you sit in front of the patient, but let the patient look behind you behind you at some distant target, like Snellen's chart. So if you're doing the retinoscopy of the patient's right eye, use your right eye and your right hand. And for the left eye, you just move slightly to the right and use your left eye and the left hand. Always concentrate on the central reflexes. Ignore the peripheral confusing reflexes, especially in a dilated pupil, because you will see a lot of peripheral reflexes. So you know about the working distance and the working length, 1 meter or 2/3 of a meter. You have to do correction for that. And some people also use a working lens. That is, you put a plus 1.5 diopter sphere on your trial frame and then you do retinoscopy. So it is for people who are a bit mathematically challenged. You don't have to do any arithmetic in the end. Whatever value you get, that is the power. Yeah, so it can also be used during dry retinoscopy to relax accommodation in the other eye. But when you have lot of lenses on the trial frame, it can cause some distracting reflexes. I don't personally use the working lens, but a lot of optometrists who use it. So how do you decide what lens to start with? Okay, that is based on the reflex characteristics. So when you do a retinoscopy, if you see the speed of the retinoscope, of the reflex, sorry, it's slow. That means it's well away from neutralization. So there's no point in starting with 0.5, 1 and all that. So you put a higher power and then you start refraction and you keep increasing with 1 diopter. If you feel the brightness, that is it's dull, that also tells you you're well away from neutralization, start with higher powers. If the width is narrow, it is far from neutralization. So as you reach neutralization, it becomes more a broader reflex, and at neutralization, it seems to fill the whole of the pupil. Also, the reflex regularity, it may be irregular in media opacities. So you know this, how do you find neutralization? If it is an against movement, you put minus lenses. If it's a plus movement, with movement, you put plus lenses. Some people also feel it's easier to work with a with movement. So what they do, if you see an against movement, they put a higher minus lens so that it becomes a with movement, and then they keep reducing the power. That is also possible, you can do it. How do you confirm neutralization? So once it's neutralized, how do you confirm that? So supposing you're having a with movement, you're adding plus lenses. Now you feel it is neutralized, you want to confirm it, you put a higher plus lens. Now it will become an against movement. So that helps to confirm neutralization. Also, you can move back and forth. That is, from neutralization, if you move forwards, you'll get a with movement. If you move back, it will give you an against movement. Now, pseudo-neutralization is described in some books. You can do this, like in higher myopic errors. So you see it is a dull, motionless illumination of the whole pupil. So what you do is use the concave mirror. That is, you put the sleeve up, so you have a concave mirror effect, and now you'll see a with reflex. But this with reflex has to be neutralized with minus lenses. So you keep putting minus lenses until you reach neutrality, and then you pull the sleeve down so that you get a minus, you get the plane mirror and an against reflex, and then you keep adding minus reflexes to reach neutrality. So in astigmatism, always measure the power, and then, before measuring the power, determine the axis of the meridian. So if you see there is a break in alignment between the retinoscopy reflex and the pupillary or the retinal reflex, that means you have to, your axis is not correct. You have to rotate the streak until this break disappears. Also, you look at the width and the intensity of the reflex. So if you see it's a thick reflex, that means you're off axis. So you have to move your retinoscope, you tilt it so that, move the reflex so that it is on axis and it's narrower. So a reflex beam which is thinner and brighter tells you it is better aligned. Also skewing. Skewing is when the streak reflex moves in a different direction from the pupillary reflex. Okay, so then that means you know it is not moving in the same direction. Then you align the axis of the retinoscope. Also in this you can use the concave mirror. Once you have got the axis, you raise the sleeve, narrow the streak so that you can find out exactly, like it comes like a line, so you can find the axis of the retina or axis beta of the cylinder. Straddling is also a bit theoretical, I think, but you can do this for confirmation of the axis with, you put the correct cylinder in place, that is the axis. You think it is at 80 degrees. What you do is you move the axis of the retinoscope 45 degrees this side and 45 degrees this side. So whichever side it is narrower, that is the side towards which the axis is. So you can again move it towards that side and then again straddle on both these sides. So how do you find the power? So once you've got the axis, now you have to find the power. So you use it with two spheres. That is the easiest. with a sphere and a cylinder, or 2 cylinders are all possible, but the easiest is with 2 spheres. Also, a commonly asked question from the PGs is, how do you find the axis? So remember, if it is the direction of movement of the retinoscope. If you're moving it horizontally, so it is a vertical beam, but you're moving it horizontally. So you're moving this side. So it is 180 that you're looking at. If you're moving the retinoscope vertically, it is the axis 90 degrees. So if you're moving it like this, that means this is the axis and it's 45 degrees. And there you have to write the neutralizing power. Okay. So that's how you draw the retinoscope reflex. So difficult situations are in the presence of media opacities, high errors. So always look out, see if the patient has got his spectacles. That's the best clue that you can get. Otherwise, if you feel it's a high error, you try a +5 or a -5 lens and see, then you'll get a better reflex. In keratoconus, you get a scissoring reflex, but that is because some part of it is hypermetropic and the other is myopic, so you get that conflicting shadows. In gross squint, always you occlude one eye so that the deviating eye takes a fixation or looks straight, and then you can do the retinoscopy. Now, autorefractometry advantages are it's quick and simple. Anybody can do this, and no pupil dilation is needed. You can get a ready-made printout of the prescription. You can get a keratometry values and the IPD. But disadvantages, it have accommodate. Patient can accommodate, and you can get an instrumental myopia, causing an overestimation of myopia or underestimation of hypermetropia. Also, near vision evaluation is not possible. Also, in the presence of hazy media, pterygia and keratoconus, it can be a problem. So control of accommodations, what we all use now are the closed loop autorefractometers, where a fogging mechanism is used to avoid accommodation, but this may not be adequately neutralized. So you have open field autorefractometers that are coming up, which eliminates accommodation, and this allows a binocular field of view through a window. So the patient is actually looking at a distant target. So this is just a picture to show you that, where you have a wide view window that avoids instrumental myopia, and it also you have a near vision reading segment. So you get a near vision values also. So to end, you need to know some type of objective refraction. Machines cannot be dependent upon. So basically, I think you have to know retinoscopy, and your personal knowledge and skill will be there with you all throughout your life. But however, retinoscopy comes only with practice, and you have to give some time to learn the art of retinoscopy. Thank you so much.
Thank you, Dr. Sudha, for giving beautifully all the tips for doing a good objective refraction. Now we have got a value by objective refraction. How will we apply it subjectively to the patient? So to give a good knowledge of it, I am inviting Dr. Rani Balamurali Krishnan from Amardeep Eye Hospital, Kollam, to speak on the topic, sharpening the skills of subjective refraction.
Started. Good morning all. So I'll be talking on subjective refraction. So the aims of subjective refraction, it is meant to get the ideal spectacle power, and it's carried out after objective refraction or even without that. It's done usually 3 to 4 days after hometropine or cyclopentylate refraction and 14 days after the use of atropine. So the steps are monocular subjective refraction, then binocular balancing and correction of near vision. Starting point is based on the retinoscopy values, autoref readings and present glass readings. So you can get the best vision sphere and cylinder through trial and error method. Then selection and verification of the baseline starting point. Then you do the refining and refining the power and axis of the cylinder. Then refine the power and finalization of the sphere. So after objective refraction, make the correction for your working distance. Either add minus 1.5 ds for 2/3 of meter or remove the working distance lens if one was used. So this depends on the patient's response, and determination of astigmatic portion is more complex when compared to the spherical one. So we have all this neuroarmamentarium, that is astigmatic dial, Jackson's cross cylinder, astigmatic block and fan and stenopic slit, Keratometry, corneal topography, abrometry and AR readings also help you to determine the amount and orientation of astigmatism. You should have an idea of the Strum's conoid. So here the vertical meridian will be focusing, giving you a horizontal line, and the horizontal one will be giving you a vertical line. In between you will be having the circle of least confusion. So how to use an astigmatic dial? Suppose this patient is having a compound hypermetropic astigmatism. So this patient will try to try to accommodate and get one meridian focused on it, on the retina. So in order to, with the help of accommodation, in order to avoid that, you have to put a fogging lens. This will reduce the visual acuity to 6/18 or 6/24, and the astigmatism will be made to a compound myopic astigmatism. So then you ask the patient to look at the astigmatic dial, and they'll be seeing that horizontal line which is closer to the retina as a clearer one. So then you have to push the anterior focal plane backwards onto the retina by putting a minus cylinder at 90 degree. Once all the axis, all the lines of the astigmatic dial become clear, that is the end point of the cylindrical power correction. Now you have to remove the plus sphere. Slowly you have to reduce the fogging lens by in minus 0.25 steps and find the best corrected visual acuity. You can use a Jackson's cross cylinder also. So this is a combination of two cylinders kept at 90 degree, or you can consider it as a spherocylindrical combination where the power of the sphere is half that of the cylinder. So this gives you a greater accuracy. You can discover if a cylinder is present or not. You can refine the axis. You can refine the cylinder power. So this patient is having a spherical error, and you can put the JCC in such a way that in one axis at 90, the other at 180, then flip and see which whether there is any choice for the position. So if all the positions are same, then there is no cylinder. If the patient prefers one position, there is definitely an astigmatism. So how will you refine the axis of astigmatism? So this patient is having the trial cylinder kept minus 1.5 at 180. You can keep the axis of the handle of the Jackson's claw cylinder parallel to the axis of the test cylinder. You can see the red line, that is the -1, and the black line in the JCC, that is the +1. So slowly give two flip choices and ask them which one is clear. Suppose the patient is saying that the first position is clear, then you have to slowly rotate it towards the test cylinder being a -1, you have to rotate it towards the minus, that is the red line on the JCC. If the other position is clear, you have to rotate it to on the second one, you have to rotate it towards the minus cylinder. So minus cylinder should be rotated towards the minus only. If it's a plus cylinder, you have to rotate it towards the black one. Then again give the choice. So this patient, once you refine it is a 160 degree, you can again give flip choices once more and see which one is better. If it is a high cylinder, you can rotate only 2 to 3 degrees, like -3 or -4 cylinders. If it is minus 0.25, 0.5 cylinder, you can rotate it up to 10 degrees. So how will you refine the power? So this JCC is kept in such a way that the axis of the JCC, one of the axis will be parallel to the axis of the test cylinder. Then you give the flip choice. See if one is better, then you have to add or reduce the power according to the power of the JCC, which is parallel to the test cylinder. One point to remember that the spherical equivalent will be equal in all positions. Whenever you change the cylinder, you have to change the spherical equivalent also. The end point of JCC is when all the flip choices are equally clear. For smaller power JCC, you can use a smaller JCC cylinder of 0.25. Higher power is 0.5 or -1. The other one is the astigmatic fan and block. Then you can use a stenopic slit, which is a simpler instrument. It requires only a visual acuity chart, trial frame and trial lenses. It can detect higher amounts of astigmatism and irregular astigmatism that can occurs in cases of keratoconus corneal scarring, post-surgical irregularities or severe dry eye. So the slit aperture acts as an elongated pinhole, allowing light in one axis to enter the eye. The other principal axis causes a blur in the Strum's conoid, and that will be avoided when you use a slit. The size is, it's 1 millimeter wide and 15 to 25 millimeter long usually. So this patient is having a -2 spherical. Now you can slowly keep the slit and rotate and find the principal meridian. So the patient will be seeing clearly in one axis, that will be the principal meridian. and you can slowly increase or decrease the power of the spherical lens and find out the best visual acuity in that meridian. Then you can turn it at 180 degree and then again find the spherical power. So difference between these two meridians will be the power of the cylinder, and the axis should be given in the principal meridian. Then next is the refining the sphere. You can slowly remove the fogging lens by slowly reducing in steps. The end point is when both meridians are equally clear. Now you have to refine the spherical power. So once the cylinder is corrected only, you have to refine the spherical power. So this is based on the duochrome test. So it says that the red line will be focused behind the retina, and the green will be focused in front of the retina, and in between the yellow will be focused. That should be the ideal point. So in the second picture, you can see that the green is, the red is behind and green is in front. You have to ask the patient to look at the color charts and ask them which one you can see it as black and boldest. So that will be the and it should be, and if the red is clear, I mean if the letters in the red is clear, that means it is a little undercorrected, and you have to give a negative power to move the red backwards. And if it's a green that is clearer, then you have to put a convex lens. So the mnemonic is, if it is a ram, that means red. For red you have to add minus, for green you have to add plus, that is gap. Then more about duochrome. Can we do this in color blind? Yes, you can do it in color blind because the test is based on chromatic aberration and not color vision. And if accommodation is overactive and the patient may accept more minus, you do it under cycloplegia. And it can be used only if the visual acuity is 6/9 or better, as they need to distinguish between 0.5 differences. And the last one in your trial set is the pinhole. It's 1.2 millimeters size, and it can be from 0.9 to 1.75 millimeter. It's also effective. The principle is that light passing through the principal meridian will go undeviated. Sorry, principal axis of the lens will go undeviated, and there will be no blur circles. And the light will fall on the fovea. In order to make it fall on the fovea, you have to correct the IPD once you put the pinhole. And it can detect non-refractive pathologies also. So outcomes of pinhole is, if it improves to best corrected visual acuity, it means there is a refractive error. If it does not improve, it means there is an ocular or a neurological issue. And if it is worse, that means there is a macular pathology. If it's better than BCVA, there is irregular astigmatism. So the cardinal principles in doing subjective refraction, it's both an art and a science, and patients do not always respond accurately during testing with JCC or during duochrome test. So starting with an objective assessment of the patient's refractive error will help you to stay on target with your refraction. Keep it simple, avoid needless detail or jargon, maintain your patience to avoid frustration, grow slowly when needed, and try to make choices as easy as possible. Provide encouragement, especially when you refract a hard patient who is hard to refract. Proceed with a purpose. Do not offer more choices than are necessary to establish your endpoint. Boredom and fatigue can result in poor subjective responses. Thank you for your personal patience.
Thank you, Dr. Rani, for enlightening us on subjective refraction. Now you have found monocularly what more to be done. To speak on this, I call upon Dr. Anita Balachandran from Regional Institute of Ophthalmology, Trivandrum. What more to be done after monocularly seeing in a patient?
Good morning, one and all. I thank KSOS and Dr. Dahlia for giving me this opportunity and the audience being here to listen to our talk. This is not a talk on accommodative disorders. It is just to highlight the importance of accommodation in various steps of refraction. Accommodation, as we know, is the ability to bring into focus objects at various distances by changing the total dioptric value of the eye. And refractive errors or even emmetropia, by definition, we say that parallel rays are being focused on the retina, in front of the retina or behind the retina with accommodation at rest. What happens if it is not at rest? Suppose it's a hypermetropic patient and the rays are focused behind, they exert their accommodation to bring the image at the retina either partially or fully, trying to underestimate the error. And the reverse happens in myopia. They tend to accommodate and we tend to overestimate the error. So we bring into an endpoint which is erroneous either in one eye or in both eye, which will cause asthenopic symptoms to the patients with correction, or sometimes we might not correct it because he's having the normal visual acuity. It is by his accommodation. So what's the role of accommodation in these various steps? Objective refraction, we know that we are relaxing it because it's very active, especially in young adults and in kids. And in monocular subjective refraction to get the power, and in binocular balancing to get the comfort of the vision. The first one gives the clarity, second one gives the comfort. And to find out the amplitude of accommodation, especially in near vision, to give the near vision comfort that is different from near ad in presbyopia, which we identify by a technique called dynamic retinoscopy. And again, the amplitude of accommodation is needed to give the near ad. How to keep accommodation relaxed? Classically, we know it's by the cycloplegic agents and by fogging. And fogging is applied in objective retinoscopy, like Dr. Sudha said, when you put your working lens, which again acts as a fogging lens to control accommodation to an extent, and in subjective monocular refraction and in binocular balancing in some way or the other. What is fogging? She has already told we are building up plus spherical power such that we are converging the lens, the image on creating an artificial myopia and causing a blurring of the vision, so that any further effort of the patient to accommodate will only blur the vision. So actually the patient is forced or made to relax his accommodation. And then by serial reduction of the power we have induced, the plus power we have added, we titrate and find out until there is no further improvement vision or the normal 6/6. And which are the steps where you apply it in monocular subjective? The initial maximum plus maximum visual acuity before the cylinder power and refined axis is finalized. She has already told that. Then once you get the final correction by reducing the plus power you have added in the first step to get the sphere, you do your cylinder power refinement and axis. If you find that your cylinder power has changed by 0.5 diopters, or if the axis has been changed by the JCC, then you can again fog and find out the final maximum plus maximum visual acuity, or in this step we can add the duochrome test to finally titrate and finally confirm the sphere modification. And procedure I'm not going, she has already mentioned. How do you know your fogging is satisfactory and sufficient? If after fogging the patient is reading the pre-fogged visual acuity or the line close to it, that much of fogging is not sufficient for that patient. So you increase your fog and then defog as we have explained to get the maximum improvement. And once you have found out the subjective refinement and refraction, what is binocular balancing? That is to aim that the accommodation is balanced and used equally between both eyes. That is called spherical equalization. There are several techniques for that. But what is the need for this binocular balancing? Monocular refraction is aimed to refine the power of the refractive error fully corrected. In binocular balancing, though we are adding or reducing powers, we are actually balancing the accommodation and not the power. Refractive error and accommodation demand may vary between both eyes, especially in high powers, high emmetropia and in anisometropia. So equalizing the visual acuity in monocular each eye doesn't mean that you are equalize the use of accommodation between the two eyes. So equalizing accommodation aims to reduce the anisoconia and thereby the balance and to provide comfortable binocular vision. So what are the techniques? The techniques can be dissociation methods or non-dissociation method, and it all use fogging in one way or the other. In dissociation methods, we fog both the eyes, and in non-dissociation method, we fog the non-tested eye. Dissociation, you can say the easiest dissociation is the alternate occlusion. When you alternately occlude and not making both eyes use the same, it's actually dissociation. Or you can induce a prism of equal strength in both eyes such that you are differentiating or separating the images of two eyes so that the patient can compare between the vision of each eye simultaneously and assess whether they are using it equally. So the alternate occlusion, you start by fogging both eyes, then you alternately occlude each eye, and if you find that the patient is having equal clarity in both eyes, the accommodation is balanced. If one image is found to be clearer, you have to add a plus 0.25 sphere. We have always wondered in the initial stage why this trial set is having this 0.25 sphere, but that is being used in so many steps, not for actually refraction. And so once you add and make that clearer eye balanced, you again alternately occlude and see if it is either they are seeing the images in both eyes equally blurred or equally clear. If again the same eye shows a clarity, you can add one more time plus 0.25 and then again try the alternate occlusion and balancing. And then once it is balanced or equally seen by both eyes, start the defogging and find out the final thing. And whatever power has to be added to balance it has to be added to the original monocular subjective refraction. So this is a patient. You can see this is our power. We have fogged the lens. Now you alternately occlude and you find that the right eye is clearer. So you add the plus 0.25 to that eye, and this whatever has been added to be added to the original thing. The second thing is the prism dissociation. We use vertical prism because up and down separation is easily identified. It can be either 3 diopter prism or 4 diopter, but it should be equal such that conventionally base down in one eye such that the upper image belongs to the right eye and base up in the left eye where the lower image belongs to the left eye, and patient can compare. So fogged, then the prism is introduced, 4 is introduced. If it is equally blurred, he will see like this. We are asking them to look at the fogged line, 612 line or 680. If one eye is, one image is clear, this is the upper one, so that belongs to the right eye, and so you add the plus 0.25 to the right eye and again ask the patient to compare, and rest of it, the procedures are the same. This is an even more specialization to the prism dissociation where you fog and then introduce the prism and ask to see the duochrome chart, so that upper chart belongs to the right eye, lower chart belongs to the left eye, and patient can balance the duochrome by the same original method of duochrome Rani has said. So it is more easier for the patient, but you should have the duochrome chart. This is the non-dissociation method of binocular balancing, which is actually a simple test, the same thing we do in monocular, but only thing we are fogging the non-tested eye instead of occluding, because occlusion per se can also stimulate accommodation in the non-tested eye and can cause balance problem. So we are just fogging the non-tested eye and doing the best vision sphere. That is the swirl technique, or the alternately comparing plus 0.25 minus 0.25 again plus 0.25. If at all patient feels a difference in the testing eye by either of the swirling, you add that lens accordingly and refine the sphere of that tested eye. Once you test your right eye, fogging the left eye, and the swirling is done and refined, you fog the right eye and do it the same in the left eye. And if whatever power has to be accepted has to be added to the original monocular subjective value you got. So this is her power. So this is the non-tested eye is fogged, and you put plus 0.25. If it is better, anything, if it then change into minus 0.25 and see if the clarity is better, not it getting dark or clear. The vision has to be better, and again come back to plus. That is meaning swirling alternatively plus 0.25 test 1, lens 2, lens 1, and if the patient sees any difference, add the corresponding lens. And once you finish your distant vision, what is the role in near vision? Even when the refractive error is corrected and balanced, the patient can have asthenopic symptoms for near because of the inability to maintain the accommodation at this final distance. So that's called lag or lead of accommodation. If the amplitude of accommodation response is less than the accommodative demand at that given distance, your eye will be focused behind that object. So that's called lag. If the accommodative response for that distance is more than the demand of that distance, your eyes get focused in front of the object, and that's called lead. So testing this lag and lead is important in any patients who are having near blur, near headache, diplopia or asthenopia for near, irrespective of their age. And it has also been said that those kids who are having this lag in myopic kids have the risk of myopic progression also. So that technique is called dynamic retinoscopy, which is much easier than the static. It should be performed in all patients with near vision problem. Monocular estimation method is the method which is commonly recommended, where you wear your distance correction, then with both eyes open, you test onto the retinoscope by putting this chart, this card on this head of the retinoscope, and patient is asked to read the letters on the card aloud, so that he is exerting all the accommodation needed for this distance. Suppose you see a significant plus reflex, you neutralize it with plus lenses, with movement, you neutralize with plus lenses, and if you see a negative movement, you have against the movement, you have to neutralize with a negative lens. 0.25 to plus 0.75 movement, which can be neutralized with a 0.25 to 0.75 is normal. So any movement which is neutralized with more than plus 0.75 is a lag, against the movement is a lead, and if it's a reflex are equal between two eyes, those are the signs for accommodative dysfunction. And in refractive steps, high accommodative lag is seen when you have it to a hypermetropic side, either by over minusing the myopic power or by under plusing the hypermetropic power, or in accommodative insufficiency. So by ensuring that the accommodation is used, relaxed at appropriate steps, you can ensure that you are giving a binocular vision both for distance and for near with good clarity and comfort. Thank you for your patience here.
Thank you, Dr. Anita, for that very informative talk on accommodation in refraction. So I invite Dr. Dahlia to give her talk on fine-tuning spectacle prescription.
So you have already heard what all things are to be done when a patient comes for refraction, the objective, subjective, and the method of binocular balancing from the previous speakers. Now, after the distant correction is over, if the patient is over 40 years, they will tell, I can see clearly at distance but can't read my newspapers or my mobile screens clearly. Here comes the importance of presbyopia correction. So the general guidelines for the presbyopia correction is the near card should be held at the ideal working distance, which is customary to the patient, which might differ in different patients, and always choose the lens strength that makes the letters clearer and not larger. Always check the range of near vision and try to keep the near card in the midpoint of the range of a near vision. And in some cases, stronger ads may be required, especially when the patient might have to be given low vision aids. Now, what about the relationship between age and accommodative amplitude? Accommodative amplitude is a difference in dioptric power of the eye when the eye is focusing at distance and at near. The difference is called the accommodative amplitude, which decreases by age. In a young child up to of 8 years, there is a good accommodative amplitude of around 14 diopters, and it decreases by 1 diopter every 4 years, so that from 8 to 40 years, it decreases 8 diopters. So at 40 years, the accommodative amplitude will be 6 diopters. It again decreases at the rate of 1.5 diopters, and at 48 years, it comes to 3 diopters. And the rate of loss is less after that, 0.5 in every 4 years. So by 72 years of age, there is no accommodative amplitude for a person. Now, what are certain facts in presbyopia correction? For all optical calculations, we keep 40 centimeters as a reading distance by default. So to focus from infinity to 40 centimeters, that is the accommodation amplitude. what is required is plus 2.5 diopters. That is 100 by 40 or 1 by 0.4 in meters, that is plus 2.5 diopters. And 1/3 to half of this accommodation has to be kept as a reserve for comfortable near work of the patient. And because the part of the accommodation is used for distance itself, hypermetropes will have early presbyopic symptoms and myopes will have a late presbyopic symptoms. And early symptoms and correction may be required in patients in professions with shorter working distance like goldsmith, watch repairers, etc. Now, to find the near rad, the patient should wear the full distant optical correction, which have been found out already by what have been told. And the near vision is tested by the Jaggers chart. You can see the Jaggers chart. The chart should be held at the habitual working distance of the patient, and always inquire about the kind of near work requirement, what is required for the patient. And the near visual acuity is recorded, which is the smallest line of letters, and in illiterate patients the smallest shape which is seen clearly. Now you determine the near rad to see the smallest letter what is required. Now the different methods to find, these are the different methods to find the near rad. We will go through some of the important ones. To find the near rad by determining the amplitude of accommodation, for this you determine the near point of accommodation with the help of the RAF ruler. While checking this, the patient has to wear his full optical correction, distant optical correction, and inverse of the near point of accommodation in meters is the near rad what is required for the patient. Now for an example, suppose a customary working distance of the patient is 40 centimeters and the near point of accommodation you find by RAF ruler is 50 centimeters. So the amplitude of accommodation what the patient has is 1 by 0.5, that is 2 diopters. This is what the patient has. Now what should be the near rad for this patient for the working distance of 40 centimeters? So the accommodation required for 40 centimeter working distance is plus 2.5. Of this 2 diopters what the patient has, half has to be kept as a reserve. So 1 diopter has to be kept as a reserve and what is left is only 1 diopter. So the amount of near addition required is 2.5 is required and the patient can use only 1 diopter comfortably. So plus 1.5 has to be given as a near rad for this patient. Now next is the tentative near rad based on age, which is routinely being used in practice, and we use the Hofstadter's formula to find the amplitude of accommodation at any age group. This is a Hofstadter's formula, and this is the chart showing the tentative near rad which is routinely practiced. Now next is to find the near rad by the plus build up method. So for this also the best visual acuity at distance is accurately has to be corrected. This can be tested either binocularly or monocularly. After the distant correction is in the frame, plus lenses are added, increased in plus 0.25 diopter spherical steps to an amount so that the patient will first read the desired letters, that is N6 in at the working distance. Now to find the near rad by the near biochrome method, which uses the principle of chromatic aberration of the eye. It is widely used actually in spherical correction, which I have been told by Dr. Rani and Dr. Anita. The red is always clearer for myope, green clear for hypermetrope, and for a presbyope who is undercorrected, red and green will be focused behind the retina and red will be more behind. So for uncorrected or undercorrected myope, if you ask, the green will be clearer. And for overcorrection, if it is the near part is overcorrected, the red will be clearer. So the patient will wear the distant correction in the trial frame. The biochrome target is held at the working distance of the patient for near correction, and ask the patient whether the optotype on the red or green, which is sharper and clearer. If green is clearer, you add more plus. And if red is clearer, you slowly decrease the amount of plus what is present until the patient sees equally on both sides, which is a near rad required for the patient. Now, the objective method to find the refractive error at near point is dynamic retinoscopy, which have been described by Dr. Anita. The distant correction has to be borne in the trial frame. The near chart is held at the working distance, and ask the patient to focus N6 letter. The room illumination should be slightly dim for doing the retinoscopy. Do the retinoscopy. The examiner sits at 40 centimeters and does a retinoscopy. The presbyope will show a width movement, and you add plus spheres to the trial frame until the point of neutralization is reached. And near add is the dioptric power of working distance minus the spherical add what you have put in the trial frame for neutralization. No, after finding the distant correction and near add, you have to give spectacles prescription to the patient. The spectacles for under 40 years, it can be unifocal, which can be used for near and distance. And if it is over 40 years, a presbyopic patient, you will have to give either bifocals or multifocals as trifocals or progressive addition lenses. For a newer presbyope, it is better to always give progressive addition lenses, but always forewarn the patient about the peripheral distortions which will be present when they are first using it. And bifocals, when you are giving, there will be a clinically significant gap at the arm's length. It is always better not to change the add type. If the patient is using bifocals, continue with that if the patient is comfortable, especially in elderly patients because of the risk of fall. Bifocals can be of three types. This is the flat top or the D bifocal, the half moon crescent or the round top, and the executive bifocals or the Franklin type. It is always necessary so that the optic center of the glasses should be in the pupillary axis of the patient for comfortable and visual clarity. And there comes the importance of measuring the pupillary diameter. You also have a far pupillary diameter and near PD. Near PD is always 3 to 4 millimeters less than the far. You can either measure it as binocular PD when you will have a single value, or you will have a monocular PD when you will have two values which might be equal in both sides, or a slight difference might be there. It can be measured by using a pupillometer or a PD ruler like this. There are also websites can also have virtual PD measurement apps are also available, because all online trading is there. So you also have websites for virtual PD measurements. Optic center is also important in while you are prescribing prisms. Decentering of the lenses can induce prisms also. So after all this, when you are handing out prescription to the patient, what all things should be important? The name, the age, the date, the name, signature of the prescriber, the right eye, left eye, all should be properly seen for. The spherical lens and the cylindrical power, when you are writing, the plus or minus sign should be properly written. If the number is less than 1, always put 0 before the decimal number. If you are not having any power, write it as plano. The sphere, if it is not having, write it as plano. The cylinder, when you are writing the axis, better than using signs and all the arrows and everything, you write the number and properly superscribe the degree symbol, because otherwise it might be mistaken for 0. Then the type, progressive, constant wear, all have to be written. Shell frames or multi-coated, whatever additions you can have, you have to write in it. IPD might be either by the optician, or you can even take it and write. Higher powers, always write the back vertex distance has to be mentioned. That is the distance between the lens in the trial frame and the apex of the cornea. If prisms are there, you have to note the power of in prism diopters and the direction base up, down, everything has to be written, and the prisms has to be split between the two eyes. For near add, either you can write the near add what is required, or you can add with the distant correction and write the number what is as -5 add +3. So you can add that and write it as -2. And clinically necessary, other these material type, everything can be written as in a spectacle prescription. For children, you can write polycarbonate lenses, colorful frames, everything like that. This is accommodative esotropia, child wearing executive bifocal spectacles. One-eyed patients, the other eye is emmetropic, you can give protective glasses, and if one eye is slightly myopic, you can write balance so that the optician will put some minus lens on the other side also, because that will give a cosmetic appeal. Any other specific indications also you can write. This was before handing out the prescription, always have a word about choosing the spectacle frame to the patient also. This was a patient who came to me with telling that she went for change of spectacles. She had the new prescription and what is present in her spectacle is the same. But she is not comfortable for her reading, especially when he is sitting. She is comfortable only when she is lying down. That was the complaint what the patient was telling. You can see it is a loose fit frame and the height of the spectacle frame is more. So whenever this near part of the progressive lens will come to her pupillary axis only when she is lying down. So she is able only to, so the advice was given that choose a proper frame for that and have the same prescription. So always tell the patient when they are choosing the frame also. So to conclude, refraction and spectacle prescription is art of improving vision without medicine or surgery. It is always a problem solving. What we measure is always not what we give. What is comfortable to the patient has to be given. History plays a big role. And always examine, diagnose and take treatment decisions. The goal is always a simple prescription which satisfies the visual need of the individual, and explain and show binocularly before you hand out the prescription to the patient. Thank you.
Thank you, madam. Now we've got time actually for a lot of questions.
If you have any doubts, you can clarify with the speakers. I don't.
I do have something to mention. Not enough doctors explain to their patients about the right posture and position of using presbyopic lenses. In my daily OP, I've got unnecessarily high amount of patients to whom I need to explain this. Like they've come from various places. They just come for a second opinion because of this. Yeah, and so that you will not see clearly when you bring your head down and look at distant, try to read with your head down. That is not explained well enough to any patient. So a lot of people come with that complaint. Again, lying down and watching TV. That's another issue that many people have, and this is not, I don't know if it's whether our people do not understand it, the importance of it, but it is not explained enough. I think we should all try to do that. After all, giving this, like Madam said, it's more an art, and you have to make them comfortable as much as possible. Otherwise, all our efforts are gone to waste.
I could not find out when that patient who came, but I'm seeing better only when I'm lying down. I was just stunned. What is she telling and all. Only after some time I recognized that is. And what as Sir told, the thing is, this all actually happens with persons working in bank. They keep all their desktops towards the side. So when they look like this, I will not be able to see through the progressive lens to the. So those are also complaints and should be explained properly to the patient.
One more thing is people who work with multiple monitors, suppose air traffic controllers and other such people, they need to have presbyopic glasses with a wider area. Yeah, so that is definitely important.
Madam has a good example to tell.
Sir said, I have a patient whom I have to see every day at my house, right? He's a doctor and his prescription is high myope and he needs ad. And he's like he said, he wants to see his monitor and prescribe the patient. Then he wants to see who is waiting outside. Then he wants to write in some other distance. So it is very difficult. So what I did is, he's using -5 and add of +3. I put another stick-on glue, which can be raised, which can be brought down. So when he's looking at the monitor and working and all, he'll put this add of +0.75 onto his original glass, and he'll keep it like that. He said he doesn't mind doing all these gimmicks. I want clarity of vision. So he'll put it up and he'll write, he'll talk to the patient, and then he will do this. But he's happy. Our aim is to make them happy.
It's Madam's husband itself. That is why Madam told I have to see him every day.
there are no more doubts, then I would request our chairperson to, yes, yeah, please.
Madam, in premature presbyopia, without use of any drugs and all, what minimum age can we prescribe AD?
Most of these patients might be early hypermetrope. So by fogging and all, you have to find whether, see whether the patient. So if you give that after the fogging, if you give that for the distance itself, they'll be comfortable. When they tell all these symptoms, they are not comfortable or find. So when they are telling all these symptoms, you have to find out what is, or it might be some, as madam told, it might be a lag of accommodation also. So you have to find that also.
And many a time now, because of the screen time and use and all, most of them are having accommodative spasm, which might be the cause of this decreased vision for near. So we'll have to see, rule out if it's a spasm, and even otherwise, they will be having some amount of manifest hypermetropia, which also be taken out by fogging and whatever, and the occupational distance also. So there's no age, Amjit. Whatever is the symptom, you have to find out why this reading near vision problem is there. Is it the lag of accommodation, it's the spasm, it's the early presbyopia, or it's the MH, or if it's occupational requirement, is something else.
Dr. Dania, can you give a little more explanation about that executive bifocals or a 6 accommodating diplopia? A little more, how you go on with it, how you start with it.
The line of it, the line should be bisecting the pupil. Actually, we write it as execute.
How to decide about the accommodating diplopia, which child to give and
You do your refraction to see whether there is any hypermetropia for full cycloplegic atropine refraction to find out the cycloplegia for that. And you give, suppose the patient has, the child has got hypermetropia, accommodating esotropia will be more for near. So you do the refraction. If there is any hypermetropia, you prescribe it. When the patient on follow-up comes again, the distance is corrected, the near is again present, then you check for the AC bar A ratio, and if the AC bar A ratio is more, you prescribe bifocals. Then the prescription should be an executive bifocals with the line bisecting the pupil.
At times, you will have to maintain them on homemade for some more time also, if they still can't adjust with it.
even after giving the
For a while.
Anything more? Thank you all for your kind attention.
Thank you, madam. So now I would instruct Dalia madam to hand over the memento to Dr. Sudha Sikhi. Thank you. You can take a group photo. You've got time for that. Next session, sir, under Radharaman sir, Vijay Raghavan sir. Speakers, please come forward.